Welcome. We apologize for the technical delay with Zoom, which everyone has grown to love. I'm going to introduce our fourth annual Patient and Family-Centered Care for Pancreatic Diseases, broadcast here from the University of Michigan Medical Campus. I'm Matthew DiMagno, the course director. I'd like to have a few brief announcements. Welcome. We have over 250 people who have registered, spanning the United States, east, west, north, south. We also have people who have registered from London, Lebanon, Ireland, Cairo, and Germany, so welcome to all. The number of registrations is over a threefold increase compared to last year. We believe this may be due to the success with spreading the news about the event, the fact that the program was developed with specific input from patients from people who attended last year, our exceptional panel of speakers, and also because the webinar, generally speaking, is easier for some to attend than in-person meetings. The webinar format has resulted in a couple changes compared to last year. All questions have needed to be submitted online. The panelists will discuss and answer the selected questions, and we will not be able to accept live questions, strength of past programs. The pre and post event surveys have also moved online. We thank all of you who have completed the 7 true-false questions. We acknowledge that there was a problem answering the 7th question, but again, thank you for answering those questions. After the meeting, please look for email communications. We will ask you to again complete the 7 true-false questions. This is a measure of gauging learning and the effectiveness of speakers. Those who have completed the true-false questions before and after the event will also be eligible for drawings for prizes. We encourage you to suggest topics you're interested in for future meetings to meet your demands, your needs. These communications will also include access to the electronic syllabus for the meeting, as well as a link to the Michigan Medicine YouTube video that has video recorded the event. Mark your calendars for next year, October 9th, 2021, when we hope to again resume live meetings at the Inn at St. John's. The program goals for today are first to provide some updates on Michigan Medicine Comprehensive Pancreas Program, and secondly, the National Pancreas Foundation Michigan Chapter. The first half of the program will focus on increasing understanding of the relationships between diabetes and both pancreatitis and pancreatic surgery, and also ways to maintain control of blood sugars. The second half of the program will focus on highlighting causes of abdominal pain in pancreatic disorders, in particular chronic pancreatitis, and the role of cannabis and behavioral therapy in personalized pain management. We'd like to thank our partners, the National Pancreas Foundation Michigan Chapter. We'd also like to thank AbbVie, which has helped to support this event today. Our planning partners include the Michigan Medicine Pancreas Program, as well as the board of the National Pancreas Foundation Michigan Chapter. We'd like to provide a special thanks to Vicki Vincent, our board secretary, for all the work she's put in to make this event successful. We'd also like to acknowledge Vicki Vincent's father, Mr. William Vincent, who recently passed away from pancreatic cancer. Again, thank you all for attending. Please enjoy the event. I'm now going to introduce our first speaker. This is Dr. Richard Kwon. He is Associate Professor of Internal Medicine, Division of Gastroenterology and Internal Medicine. He is a pancreatologist, interventional endoscopist, co-director of the Michigan Medicine Comprehensive Pancreas Program, and board member of the National Pancreas Foundation Michigan Chapter.
Good morning, everybody. I would like to welcome everyone to our 4th annual Patient and Family-Centered Event for Pancreatic Diseases. As mentioned, I'm Richard Kwon. I'm one of the pancreatologists here at U of M. And I'm going to be give a brief update about our comprehensive pancreatic program. The only disclosure I have is that I'm doing some research with AbbVie. So our comprehensive pancreas program is a way for us to organize and formalize our pancreatic care here at University of Michigan. We established our program in 2018. We have 4 pillars in terms of values for our program. The first is to provide world-class, cutting-edge, patient-centered clinical care. The second is to do this in a multidisciplinary, collaborative manner. Number 3 is to perform innovative research that helps push the field forward. And lastly, we're committed to education, both for patients and families, as well as for other caregivers. In terms of clinical care, we see a myriad of pancreatic conditions. These include chronic pancreatitis, autoimmune pancreatitis, pancreatic insufficiency, acute pancreatitis and its complications, including necrosis and pseudocysts, pancreatic disorders related to cystic fibrosis. We see neoplasms, including cystic neoplasms, pancreatic tumors, and ampullary tumors. We also look at hereditary disease, both hereditary pancreatitis as well as hereditary and familial pancreatic cancer. In terms of our clinical care, we see patients both on the main campus in 3 clinics. These include those at the Taubman Center, the Cancer Center, the Rogel Cancer Center, and Genetics Clinic. We also have an off-site clinic in West Ann Arbor. Pancreatic care is ultimately multidisciplinary, and this is something that we are committed to and take pride in. So in terms of, we work with multiple subspecialties, including surgery, radiology, pathology, oncology, endocrinology, as well as pain and behavior specialists. The culmination of this multidisciplinary collaboration are in 2 case conferences. First, there's a benign pancreas conference, which meets twice a month. This includes caregivers from surgery, gastroenterology, and radiology. And this is where we discuss cases related to benign pancreatic diseases such as cystic neoplasms, as well as acute and chronic pancreatitis. We also have a weekly multidisciplinary tumor board. This is at the Rogel Cancer Center, and this includes caregivers in surgery, gastroenterology, radiology, pathology, and oncology. Besides clinical care, we are involved in innovative research and take pride in trying to push the field forward. We have ongoing active research, both clinical research as well as basic science research in chronic pancreatitis, pancreatic insufficiency, acute pancreatitis, and in terms of diagnosis as well as dealing with necrosis and pseudocysts. We have research ongoing in cystic fibrosis, cystic neoplasms, solid pancreatic tumors, as well as hereditary and familial pancreatic cancer. We've been very successful in our research endeavors. We've had over $10 million of funding in 2018 and ongoing. We've had multiple publications, including clinical studies related to acute pancreatitis and chronic pancreatitis and pancreatic insufficiency. In both, we've also had recent grant funding in both of those. We've also had Dr. DiMagno has been involved in guidelines and chapter writing for acute and chronic pancreatitis. We also have ongoing active enrollment in the following pancreatic areas: acute pancreatitis, cystic fibrosis, and this is centered out of the pulmonary department. We also have ongoing research related to cystic neoplasms, as well as pancreatic tumors, and we have multiple ongoing studies with hereditary and familial pancreatic cancer. If you're involved or interested in studies related to cystic neoplasms or hereditary pancreatic cancer, the contact information for our study coordinator, Sarah Volk, is listed here. Those specifically related to solid pancreatic tumors, should be addressed to the Rogel Cancer Center at the phone number addressed here. We are also committed to education, and as I mentioned before, this is both for patients and families as well as caregivers. And so we have patient-centered events such as the one that you are all participating in today. And then we also have support groups that are currently on hold because of this pandemic, but hopefully soon will be relaunched. We also are involved in developing CME events for physician caregivers and nurse caregivers. And then we are also lastly involved in medical student education as well as medical resident education and fellow education. And we are hoping soon to have a fourth-year fellowship dedicated to pancreatology. So based on all of the above, we have been named as one of the National Pancreas Foundation Centers of Excellence, both in pancreatitis as well as pancreatic cancer. We are the only such center here in the state of Michigan. So I hope I've been able to demonstrate that we are busy and productive and looking forward to a productive future with you. Thank you, everyone, and please enjoy the rest of the event. Thank you.
Thank you, Dr. Kwon. I'm going to introduce our next speaker, Robin Winke, who has a master's degree in social work and certificate in family counseling. She is a therapist at Winke Counseling, located in Troy. For the relevance of today's event, she's also the chair of the National Pancreas Foundation Michigan chapter. She is personally responsible for launching the chapter and establishing a monthly support group meeting. Welcome, Robin.
Thank you. The National Pancreas Foundation was established 23 years ago by Pater Biersick and co-founder Jane Holt. The Foundation's mission is to provide hope for those suffering from pancreatitis and pancreatic cancer through funding cutting-edge research, advocating for new and better therapies, and providing support and education for patients, caregivers, and healthcare professionals. The NPF supports research through physician programs by funding research grants, fellow symposiums, and providing awards. The NPF provides medical education opportunities, and they have the National Patient Registry. The NPF shows their support through our featured programs, the Animated Pancreas Patient, our state chapters, our patient education, our state support groups, and the NPF centers. Our Michigan chapter was established 4 years ago. In 4 years, we have established a volunteer board. Dr. Matt DiMagno, our medical director and host for today, along with other healthcare professionals, patients, and caregivers, comprise our Michigan board. Our board has worked together to provide education, events for patients and caregivers. We have provided support through our monthly support groups. We have engaged in fundraising activities, which include partnering with other organizations and foundations. The NPF centers are centers identified as treatment centers for patients referral based upon specific criteria. At the approved NPF centers, patients can expect excellent multidisciplinary case focus on the whole patient to include experienced oncologists, gastroenterologists, surgeons, dietitians, pain specialists, psychosocial support, and more. And again, Michigan has the University of Michigan as their center of excellence. The Michigan support groups have been co-facilitated by my husband Derek and myself for the past 4 years. Currently, the Michigan support groups are on hold. The NPF has continued to partner with Inspire, an online support group for health and wellness for online support. Also, the NPF is working to implement a new mentor program for our support groups. Our Facebook page and our NPF website will continue to provide updates for support groups, changes, and future events. Fundraising is an important part of the National Pancreas Foundation. The NPF has an annual Color It Purple Challenge. They participate in the Marine Corps Marathon. In the near future, we'll be hosting the Rocking Party virtual gala with entertainment performed by the rock legend Peter Frampton. In Michigan, we have hosted ice cream socials and partnered in the dine-in and carry out and take out cancer fundraising events. Please watch for updates for our upcoming Stomp Out Pancreatic Cancer fundraising, expected in spring of 2021. The answer is yes. Volunteer opportunities are available at the NPF to either facilitate or to host a support group, fundraising, or possibly to become a board member. Thank you for your time.
Thank you, Robin, for that wonderful overview. I'd like to introduce our next speaker, my colleague, Dr. Erik-Jan Wamsteker, Associate Professor of Internal Medicine, Division of Gastroenterology at Michigan Medicine. He is a scholarly clinician, one whom I've collaborated with in a number of clinical studies. He's also a member of the prestigious Michigan Medicine Clinical Excellence Society. He's also an interventional endoscopist and a board member of the National Pancreas Foundation Michigan chapter. Thank you, Eric.
Good morning. I'm Erik Wamsteker. I have no disclosures relevant to this discussion. I've been charged with introducing the first topic for today's forum, which is on diabetes in patients with pancreatic disease. Because pancreatitis is the most common pancreatic disease associated with this type of diabetes, I'd like to provide some background definitions. Acute pancreatitis is acute inflammation of the pancreas resulting in acute abdominal pain, as well as elevated pancreatic enzymes, which can be detected in the serum. It is generally felt to be, in most cases, a self-limiting disease, as opposed to chronic pancreatitis, which results in chronic inflammation in the pancreas, recurrent or chronic abdominal pain. The downstream long-term effects of chronic pancreatitis are progressive loss of pancreatic endocrine function, resulting in diabetes, and exocrine function, resulting in pancreatic digestive or maldigestion. Diabetes is a group of disorders leading to high blood glucose or hyperglycemia. Type 3C diabetes is due to pancreatic disease. Most of us have heard of type 1 and type 2 diabetes. This is an under-recognized form of diabetes, which encompasses approximately 4 to 8% of all forms of diabetes, but it's likely underestimated. Type 3C diabetes has diagnostic criteria, 3 of which need to be present. Essentially, patients need to fulfill a diagnosis of diabetes, have a disease of the exocrine pancreas, and expert believe that their diabetes has to be associated with that form of exocrine pancreatic disease, or due to their exocrine pancreatic disease. Patients commonly actually present with symptoms from their pancreatic disease rather than from diabetes specifically. And that's because when patients present, they usually present prior to initiation of their diabetes. The key point is that most have an established diagnosis of exocrine pancreatic disease prior to their diagnosis of diabetes. Now, in the course of their disease, patients may have a clinical change where they may experience weight loss, malnutrition, or nausea and vomiting, which may prompt an investigation into the development of diabetes. It's common in exocrine pancreatic diseases, as in particular long duration of disease, pancreatic cancer, and other forms of exocrine disease. Pancreatic diabetes is felt to be due to a reduction in insulin production as well as insulin resistance. The vast majority of patients have pancreatic diabetes due to chronic pancreatitis, and that is approximately 79%, followed by pancreatic cancer, hemochromatosis, cystic fibrosis, and previous pancreatic resection surgery. Focusing on chronic pancreatitis, diabetes is present in 20% of patients at onset of diagnosis, and diabetes is present in greater than 80% at 25 years, suggesting that most patients with chronic pancreatitis will go on to develop diabetes. And the primary risk factors in that population are smoking or prior smoking, previous pancreatic surgery, and the presence of pancreatic calcifications early on in their disease course. There is an association, a relationship between diabetes and pancreatic cancer. With long-standing diabetes, there's a 1.5 to 2-fold increased risk of developing pancreatic cancer. With new onset diabetes in those greater than 50 years of age, there's an approximately 1% risk of the development of pancreatic cancer within 3 years of their new diabetes diagnosis. This may afford us an opportunity to perform pancreatic cancer screening, although the incidence is still too low. You'd have to likely, if you were going to apply an effective population screen, use a combination of new onset diabetes and other risk factors. Pancreatic diabetes is associated with complications, although the data is quite scarce. It's probably similar to other forms of diabetes, which will be discussed further by Dr. Wyckoff. It's often associated with a brittle form of diabetes. In other words, those treated with insulin have a high risk of low blood sugars and erratic glucose fluctuations. It may best be treated by a multidisciplinary team consisting of a registered dietitian, a certified diabetes educator, diabetes specialists, and gastroenterologists who often will perform screening tests for diabetes over the course of their illness. The goal is to prevent end organ damage, and this again will be further discussed with by Dr. Wyckoff. Ultimately, treatment will also be discussed with Dr. Wyckoff, and the intention there would be to correct insulin deficiency and treat insulin resistance, but of course it's more complicated than that. I will now introduce Georgiann Ziegler, who will provide a patient testimony. She serves as a patient advisor on numerous committees and boards at Michigan Medicine, all aimed at improving lives and experiences of patients. She is also a board member of the National Pancreas Foundation Michigan chapter. She's agreed to provide us her journey with pancreatic disease. Unfortunately, Georgiann is unable to attend due to illness, but we do have a video of her providing this testimony.
Hi, I'm Georgiann, and I have chronic idiopathic pancreatitis. And like I always say, pancreatitis is the gift that keeps on giving. And shortly after my diagnosis in 2004, I was diagnosed with type 2 diabetes. At that time, I had an endocrinologist due to a thyroid issue, and he basically said, "Oh, you're diabetic, watch your diet, and take these pills," which was metformin. And I thought, I can do that. A few more pills? No problem. And I realized probably a year after that I really needed to find a new physician. He just wasn't the one that was going to help me through this. And I found an endocrinologist at Michigan Medicine that worked with my gastroenterologist. And that being said, one of the first visits he said to me, "This is going to be a journey. There's going to be twists and turns and changes, and I will be with you every step of the way." To me, that meant 20 years from now, we might have to change something. And of course, that wasn't the case. Shortly thereafter, we had to add another medication to help boost the metformin, and I thought, still not a problem, just another pill. And as time went on, we realized that maybe a long-acting injection every evening might work, which was kind of scary because I've never given myself an injection. But of course, I learned to do that. His staff was there to help. One of the people actually was on the same medication and explained all the pitfalls and all of the strengths about it and tricks of how to even give the injections, which was very, very helpful. And on went a number of years. In one visit, he said, "I think we're done with the long-acting insulin." And I thought, great, we don't have to do this anymore. No, we're going to do insulin before breakfast and before dinner. And I said, oh, how does this work? And he said, you take your blood sugar levels, I will tell you how much insulin to take, and on you go. This was very difficult for me. This was a huge challenge. Before breakfast was not a problem, but before dinner was. This was before COVID, where we were staying in more. I was out and about, dinner came, and I'm sitting at a dinner table with friends. Am I going to give myself an injection at the dinner table? No. Am I going to excuse myself and say everybody out of the booth because I need to go and give myself insulin? No. So many times I didn't take it before dinner because it just wasn't easy for me. Of course, the numbers weren't coming down, and we were increasing the insulin because he's assuming that, I need more. Finally, one day at an appointment, I looked at him and I said, this isn't working for me. I want to go back to the evening dose. I can't do this. And instead of him saying, well, too bad, you have to do this, we partnered together and we found ways to make it happen. It still was a challenge. There were times I would take the insulin and not eat enough and the blood sugar would drop. And I had to figure that out. Had to ask the questions. How do I make it rise again? And I'm sure many of you maybe have had this happen. But I have found, being in isolation and during quarantine, my blood sugar levels have never been better. My A1C has never been better because I've been home and I've been able to follow the regimen that is right for me. So as things get back to normal, and maybe if I start going out and about more, I realize the importance. So I guess I would say, if I could give you any suggestions, it would be to find a physician and a healthcare team that you could partner with. This is a journey, like it was explained to me early on, and the journey is going to go on. It's not going to stop, and there's going to be twists and turns and changes. And if you have someone that you can talk to, if you can have somebody you could be transparent with, because I says they know by our numbers if we are doing things right. And of course, at that being said, we have to be able to be transparent. The day I walked in and said, this isn't working, what can we do? My hope was that I wouldn't have to take the insulin. But of course, it was explained to me the importance and how we together could make this happen. And I've seen that my numbers have gone down. My A1C is at a great level, and it's because I'm doing everything right. It's been made easy for me, and I now know the importance. I would say when it comes to diabetes, just realizing the journey that it is, that the diagnosis and the therapies that start your first visit will likely not be the same all the way through, and be open to the changes and be open to the different things that will happen and will be addressed at that time. Because I think if we are open to that, then we will have a better outcome. And if you're a family member or friend, please love us. Most of us have not done anything that brought this on. It was because of our pancreatitis. Don't assume. There's a lot of stigma with pancreatitis and with diabetes that we have done something, that we're sitting eating sugar by the spoonfuls. And in many cases, that's not the case. So love us. Learn what we need. Sometimes we need to be prodded to take our insulin or to watch what we're doing. But just know where that place is. And I hope we all have much better days. Our good days are good, and we need to be running with them.
Thank you, Georgiann. I know you're listening online. That was a very warm, heartfelt review of your life's journey with pancreatic disease. We're now going to turn to our next speaker, our keynote presentation for the first half of our program on diabetes. It's a pleasure to introduce Dr. Jennifer Ann Wyckoff, an associate professor of internal medicine and associate clinical chief in the Division of Metabolism, Endocrinology, and Diabetes at Michigan Medicine. It's also a pleasure for me because Jen and I have interacted together in the Michigan Medicine Cystic Fibrosis Center, and I've come to know her over the years. In her professional duties, Dr. Wyckoff serves as the medical director for the Adult Diabetes Education Program, the director of the Endocrine Disorders in Pregnancy Program. Her clinical and research interests include various aspects of diabetes, including insulin pumps, patient education, diabetes and pregnancy, CF-related diabetes, and transplant-related diabetes. Welcome.
Thank you, Matt, for that really kind introduction. I'm honored to be here today, and I want to thank the organizers for inviting me. So I have no disclosures. So one of the big questions that people always ask is, what really is diabetes? And it's defined by the level of glucose at which people begin to develop complications from high blood sugar. So if you look at the graphic on the right, you'll see that people develop, in this case, retinopathy, or start to develop risk for retinopathy when they have a hemoglobin A1C of around 6.5 or higher. The hemoglobin A1C is a way of measuring your average blood sugar over time. And so this equates to an average blood sugar of about greater than 140 milligrams per deciliter. This is why we pick the definition of diabetes based on the level of glucose in the blood. But what really causes that is more difficult to explain. Think of it a little bit as a supply and demand problem. Glucose is absorbed from the gut into the blood, and glucose is also stored in the liver and then released into the blood in response to a whole variety of hormonal signals. That creates the supply part of the equation. Glucose is coming into the blood. What takes glucose out of the blood and puts it into the cell to be burned as fuel? And the answer to that is insulin. Insulin literally opens a doorway in a cell to allow glucose to enter. So think of it this way. There are lots of ways that glucose gets into the blood, but really the main way it gets out is through insulin allowing it to go into the cells to be burned. So many things in this, many different kinds of problems metabolically can lead to an imbalance in the supply and demand part of this equation. And that is why we have many different types of diabetes. Most people have heard of type 1 diabetes, and they think of it as, based on old terminology, juvenile onset. So type 1 diabetes is an autoimmune attack where the body literally, its immune system attacks the beta cells in the pancreas, which make insulin, and destroy them. This is really dramatic in children, and that's why it was called juvenile onset. You can actually develop type 1 diabetes at any age, and the incidence is a little bit higher in young, like in teenagers and young adults than it is in small children or older people, but it's not much different. And so the terminology of juvenile onset diabetes is no longer considered accurate. But type 1 is a disease of the pancreas in that it is an attack, an immune disease attack on the pancreas, but it's a very specific type of diabetes. Type 2 diabetes is everything else. And that's kind of a problem because there are actually many ways that people can develop type 2 diabetes, and often there's more than one mechanism at play in any particular individual. So when you say someone has type 2 diabetes, typically we're talking about increased insulin resistance, obesity, older people, but there's so many different causes. There are genetic things that promote insulin resistance. There are genetic things that promote insulin deficiency. There are drugs that increase insulin resistance. There are also drugs that can cause insulin deficiency. And there are environmental factors. So type 2 diabetes is much more complex to explain than type 1. And what is happening over time is we're beginning to identify certain mechanisms and create new types of diabetes based on those mechanistic definitions. And that's where we come to pancreatic diabetes, or type 3C. It has lots of different names in the literature, and it tends to be kind of confusing if you try to read the literature. It's been called pancreaticogenic, pancreoprivic, type 1.5. But really, I think people are settling on type 3C as the best definition. But I still also call it pancreatic, because I think that helps explain it very clearly, that it's pancreatic disease-based. That doesn't mean that all pancreatic disease falls under type 3C. And one unique form of diabetes is what we call maturity onset diabetes of the young. This is actually a very diverse group of autosomal dominant, very hereditary forms of diabetes that are caused by single mutations. It's a fascinating group of diseases. It was actually first described here at University of Michigan, not by me, but it is an absolutely fascinating area of study. And some of these forms of maturity onset diabetes of the young are because the pancreas does not form properly in utero. And so some of these patients, certain mutations lead to very small and dysfunctional pancreases. That really doesn't fall under the type 3C category. Type 3C pancreatic diabetes is really when you have a functional pancreas as a child, and then pancreatic damage from a pancreatic disease leads to insulin deficiency. It is very common, as my Dr. Wamsteker mentioned, but actually really quite under-recognized. I tend to think of these four groups as the most common forms of pancreatic diabetes, of type 3C diabetes. And I'm not going to go into great detail, as Dr. Wamsteker did mention them, but these are kind of the four big categories. So, moving on to treatment. How does treatment for diabetes help the person with the diabetes? Well, there are lots of ways. Diabetes is a very complicated disease process, and it can cause many different kinds of discomfort, complaints, conditions that lead to decreased quality of life for some people. So you really have to think about, why do I want to have treatment? And the answer is, there's so many different reasons why. It can improve your energy. It can improve your sleep. If you're waking up because of high blood sugars in the middle of the night, causing you to have increased urine output, and you're having to go to the bathroom several times a night, that disturbs your sleep and leads you to fatigue. It can decrease your risk for, so high blood sugars increase your risk for infection, so treatment can decrease your risk for infection. That's particularly important in the population that Matt and I work with in the cystic fibrosis clinic. It can reduce nausea. High blood sugars can make you feel nauseous. So many people with pancreatic disease already have GI complaints. High blood sugars will make those worse. They'll increase your nausea, decrease the ability of your gut to move food through your gut, and it really make people very uncomfortable. High blood sugars promote weight loss. If your blood sugar is over about 200, you begin to have glucose lost in your urine. Many patients with diabetes can benefit from weight loss, and some of our medications for diabetes actually help people lose weight. But many people with pancreatic diabetes, with type 3C diabetes, are actually underweight and need to gain weight. And so in that case, controlling blood sugars will help them actually gain weight. And many other reasons. Everyone knows about the classic complications of diabetes: diabetic eye disease, diabetic kidney disease, and neuropathy, which can lead to foot ulcers and eventually amputations. All of those things are dramatically reduced by good glucose control. So there are many, many reasons, including the #1 killer of patients with diabetes, which is heart disease, can be reduced by good glucose control. One thing that we often don't talk about with our patients, and this is actually something that we all are trying to do better at, is discuss the impact of high blood sugars and diabetes on sexual function and fertility. And that's another thing that you should have a conversation with about have a conversation with your endocrinologist about. So talk to your doctor about what symptoms you have, and are they related to your diabetes, and what are your risks for complications, and how can diabetes treatment help you? So how is pancreatic diabetes treated? Well, a lot of it has to do with all of the things that increase the supply of glucose into your system. So nutrition is obvious. If you eat something that has glucose in it, your blood sugar is going to go up. That makes perfect sense. Exercise also seems pretty obvious. If you're exercising, you're burning calories, so presumably you're taking some glucose out of your blood. Sleep, that's a little less obvious, but sleep actually is very important. Blood sugars tend to go down during the night, both because you are not eating, but also because your stress hormone levels tend to be low at night. If you're having problems with sleep apnea, for example, and having very disturbed sleep because of that, or because of pain, or perhaps you have a newborn baby that's waking you up every night. There are lots of different things that can cause disrupted sleep, but those tend to raise your blood sugars in the morning. So sleep is part of this equation as well. So is pain, stress. So those are all things that are part of good diabetes care. Smoking is obviously a high risk, a huge risk factor for heart disease, as well as amputations and kidney problems, and increased risk for pancreatitis. So smoking cessation is an important component as well. And honestly, education about diabetes is incredibly important. You want to understand how all of these factors impact your diabetes specifically, and it's a little different for each person. Keeping up to date on immunizations is also important, and monitoring and medication. But let's talk a little bit more about monitoring and education. So we talk a lot about the importance of having a dietitian and having a certified diabetes educator. Now, they can be the same person. There are a few incredibly talented people out there who are both registered dietitian, nutritionists, and certified diabetes educators. And you really want to try to seek out these people. You want a dietitian who's got really good experience with malabsorption syndromes, who understands how pancreatic insufficiency, exocrine pancreatic insufficiency, affects your gut. And there are many ways that she can help you with your diet decrease some of your symptoms related to this, as well as lower your blood sugars. The role of the certified diabetes educator is a little bit more for the people who are on insulin. Now, you do want to have comprehensive diabetes education even if you're on oral medication, but the CDE can really help you as a coach for your insulin dosing and for the technology and other factors around insulin-requiring diabetes that are so important. And we know that diabetes education actually reduces both A1C and hospital admissions in patients with diabetes. So monitoring. So monitoring depends really on what's going on with your blood sugars. And that means that there are some people who really only need to test their blood sugars occasionally, and some people who really benefit from continuous glucose monitoring. And that's a huge range. So what are the targets? Well, we're hoping to see fasting blood sugars between about 80 and 130 milligrams per deciliter, and we would like to see the peak after meal blood sugar be under about 180, like 140, 150 is beautiful. And that's what we're trying to achieve. Now, how do you figure out if you're achieving that? Well, many people can have very easy, just checking their blood sugar as a fingerstick blood glucose check in the morning, and they can see that their blood sugars are in that 80 to 130 range, and that looks pretty good. If they're stable, things are going well, that's wonderful. But if people are having really high spikes or their A1C doesn't suggest that they're doing well, sometimes we'll ask people to check in the evening as well. Once somebody is on insulin, however, we're really looking for more frequent checks because we need to understand what's going on with the blood sugar to do the insulin adjustments. So in that case, we're really looking for blood sugars before each meal and at bedtime to really get good patterns. And once somebody's checking 4 times a day, often it's just way easier to be on a continuous glucose monitor. That will allow you to see what your blood sugar is every 5 minutes for a whole 24 hours a day. So continuous glucose monitors are really beneficial for certain patients. One thing that's very important to remember about monitoring is if you are ill, if you're not feeling good in some way, if you have a fever, if you're having GI issues and you're not able to eat, it's even more important to check your blood sugar at that time and not to stop checking, because that's when you're most likely to have serious complications of high or low blood sugars. And then people ask, well, how often should I get the hemoglobin A1C done? So the hemoglobin A1C is supposed to be done every 3 to 6 months, and you want your hemoglobin A1C to be less than 7%. That would be an average blood sugar of about 154. And the thing you need to know about the A1C is that it may not be as accurate in patients with type 3C diabetes as it is in other forms. The A1C is based on how much glucose is stuck to the red blood cells, to the hemoglobin in the red blood cells. So if a person has low red blood cells, if a person is anemic, the A1C may not be accurate. So the A1C of less than 7 is a standard recommendation for all patients with diabetes, but one question you should ask your doctor is, do you think my A1C is accurately reflecting what my blood sugars really are? Now, what medication is right for me? There are a lot of medications on the market for diabetes, and they all work in different ways. And I can give really fascinatingly long and complicated lectures about it. But the basic medications that are out there fall into 6 groups. Biguanides, which is represented by metformin, one of the most common medications out there for diabetes today. The SGLT2 inhibitors, there are a number of them on the market. The GLP-1s, fascinating story. I think the only drug ever derived from Gia monster saliva. And sulfonylureas, DPP-4 inhibitors, and insulins. We're going to talk a bit more about each of those classes in a slide or two. But when you're picking a drug, there are lots of things that you want to consider. And the key first thing you have to consider is what is the underlying physiology of this person's hyperglycemia. That can be all about insulin production. If a person is making lots of insulin and they are able to mount a really good insulin response, they can have a high C-peptide, then that suggests that any of these medications could potentially lower blood sugars. However, if a person has really very low C-peptide or no C-peptide production, no insulin production, then only insulin will work for that patient. So when people ask, am I going to need insulin? The first thing I have to understand is what's the physiology here? How much of it is insulin resistance and how much of it is insulin deficiency? And often you see both in the same person, just at different levels from person to person. There are other considerations as well. Is the person underweight or overweight? Does the person have complications already or other underlying conditions that make one medication preferable over another? And also there are issues around cost and other things like, does the person already have issues with their stomach, with their GI tract that are causing them symptoms? In that case, I wouldn't want to add a medication that could potentially exacerbate that. So what medication is right for me? When I'm teaching medical students or fellows, I always find it best to use cases. People remember stories better than they do lists or tables of information. So I'm going to tell you a few stories, and I hope you enjoy them. So the first story is, if a patient comes, he's an overweight man who has mild hyperglycemia and mild cirrhosis due to hemochromatosis. What would be the right medication for him? Well, he's overweight, so I don't mind putting him on a medication that promotes weight loss. And metformin, SGLT2s, GLP-1s, they all help promote weight loss. So any of those would be appropriate based on his weight. His hyperglycemia is mild, and therefore metformin, SGLT2s, or GLP-1s, which all have a mild ability to reduce blood sugar, all of them could potentially work. But wait, he has cirrhosis. Are any of these medications dangerous in cirrhosis? Well, no, actually they aren't. So that doesn't really limit this. That's good. Now, it's important to note that patients with hemochromatosis don't have, as far as I know, a huge increased risk for pancreatitis. I did look that up before this presentation, and I didn't see that they did, but we are in a pancreas talk, so anybody can correct me if I'm wrong. So I'm not too worried about him developing pancreatitis. The reason that's important is there is potentially an association between pancreatitis and GLP-1 medications. So I'd want to avoid those if he had a history of pancreatitis or risks for it, but he doesn't. So in this first case, this overweight man with mild hyperglycemia and hemochromatosis, I would start metformin, and then if I needed to add something, I'd be happy to add an SGLT2, which has very good cardiac safety benefits, or GLP-1, which also has cardiac safety benefits. Now, that's that first patient. But what about a man with cystic fibrosis? He's not overweight. He only has mild hyperglycemia. I wouldn't really want to give him anything that could cause pancreatitis, so the GLP-1s would be out. And patients with cystic fibrosis often have trouble with nutrition and malnutrition. So I'm not going to want to put him on something that's going to make him lose a lot of weight. So I wouldn't go with an SGLT2 or even metformin. I would probably pick a sulfonylurea to start. If you look at the recommendations for cystic fibrosis-related diabetes, they're really all about insulin. But if you have somebody who's only just got a little bit of high blood sugar, you can try sulfonylureas. There are papers for cystic fibrosis and sulfonylureas, but only in patients with really mild hyperglycemia. My third case, an underweight woman with moderate to severe hyperglycemia due to cystic fibrosis and a history of lots of GI issues, bowel obstructions, et cetera. There's nothing for that case except insulin. Insulin will work, but with the really high blood sugars, nothing else would bring her blood sugar down, and almost everything else promotes weight loss, and she's already underweight. So there's really no choice but insulin in that particular case. A normal weight man with a history of a total pancreatectomy following a car accident, his pancreas has been removed. He makes no insulin now. Insulin's really the only choice in that case. And then this last one, an overweight woman with a history of acute pancreatitis due to high triglycerides who's planning a pregnancy. This has always fascinated me. High cholesterol, really high triglycerides can cause pancreatitis. And so in this particular case, this is someone who would benefit from weight loss, but they have a history of pancreatitis. So I wouldn't want to use a GLP-1 because in that case, I could cause pancreatitis, but metformin, which helps with a little bit with weight loss, might be a good choice. However, she's planning a pregnancy. Well, one of the best drugs to bring triglycerides down is actually insulin, and the only medication that's really considered safe in pregnancy is insulin. So in that case, I would be putting her on insulin, even though if she wasn't planning a pregnancy, she would definitely benefit from some of the other choices. So I hope those stories helped you understand a little bit about how doctors think about choosing diabetes medications. I do want to point out that I find that in the type 3C diabetes world, insulin use is really quite common. Many patients are on insulin, but I feel like diabetes technology is often a little bit underutilized. In the type 1 diabetes population, we use insulin pumps on many of our patients with type 1 diabetes, and patients like them. It's a lifestyle choice. It reduces the number of times you have to check if you have a continuous glucose monitor. It makes your dosing insulin far more easier. So many of our patients really prefer insulin pumps. This is a challenge for our patients who have insulin-requiring type 3C diabetes because many of them are not being thought of for this. And I think that this is something that if you are on 4 shots of insulin a day, would be something to discuss with your physician. So we talked about diabetes quite a bit, and I think it's really helpful for people to have a checklist because there are many points that you have to remember. So here's my version of a checklist for you. You want to think, am I doing the right thing from a diet standpoint? Exercise, sleep. Have I gotten all the education I need? Am I up to date on my immunizations? Am I monitoring the way I'm supposed to? Am I taking the best medication for me? And then you want to think, is all of this work I'm doing achieving the goals, the targets that I need to achieve to stay healthy? And those targets are really your A1C of less than 7, your average glucose of less than 154, or if you're on an insulin pump and a CGM, your CGM time and range of greater than 70%. Is my blood pressure where it should be? We haven't talked at all about blood pressure, but it's very important for kidney health to have good blood pressure. because hypertension is another leading cause of kidney disease. So we want to keep the blood pressure under 135/85, and so that's another important point on any patient with diabetes checklist on how to stay healthy. And also cholesterol. Now, cholesterol can range dramatically in patients with type 3C diabetes because some patients have severe malnutrition and their cholesterols are very low, but other patients, like that obese woman that I was describing who was planning a pregnancy, can have very, very high triglycerides, very high cholesterol. So being aware of where your cholesterol is and making sure that you're on appropriate treatment, if necessary for it, is another point on your checklist. And then keeping up to date on all your screenings. Patients with diabetes, it is recommended that they have an eye exam annually, and that's because diabetic eye disease does not usually cause visual changes until there's actually visual loss. So you can be walking along, seeing everything fine, and if you suddenly have a bleed from proliferative diabetic retinopathy in the back of your eye, you would see like a black curtain come down over your vision or a big black ink spot and have no idea that it was going to happen until it did. So having the annual eye exam allows the eye doctors to see if there's anything going on in your eyes that needs a treatment to prevent bleeding, to prevent vision loss. So please, please, please do get your annual eye exams. Kidney labs are very important. Everyone should have an annual creatinine to assess kidney function, as well as an annual urine protein check, most commonly a urine microalbumin to creatinine that should be under 30, to assess their kidney status and whether their kidney disease is related to diabetes or not, if they do have kidney disease. And also foot exams are very important, so an annual foot exam at least is recommended. Kind of going through all of this with your physician and saying, what do I need to focus on for me personally and my diabetes can really help you focus on what's most important for you, and it's different from patient to patient. So what else should I know about diabetes? Well, alcohol is very important to be aware of, and I'm going to tell you a bit of a personal story here. Unfortunately, my personality made me the dorm mom when I was in college. And so I was the person who got woken up if there was any kind of, crisis in the dorm in the middle of the night. 2 years in a row, we had students in my dormitory have hypoglycemic seizures in the middle of the night from type 1 diabetes. And what is very important to know, and this is classic for young patients with type 1 when they first go away to college, is alcohol can cause low blood sugars in the middle of the night if people are on insulin or sulfonylurea medications. So it's very important, if you do drink any alcohol, to have a very serious and frank conversation with your physician about how to drink alcohol safely in relation to your diabetes medications. Obviously, this is a pancreatic talk, so many people have been told not to drink alcohol at all by their physicians. That's aside from my conversation. My conversation is, I don't want people having seizures in the middle of the night from low blood sugar. So it's really important to understand how to drink safely if you are going to be drinking alcohol. I believe that Matt mentioned that I am the director for the Diabetes and Pregnancy program here. And so pregnancy is near and dear to my heart, and it's very important to understand, if you're a young woman with diabetes, if you're planning a pregnancy, that high blood sugars can cause birth defects. Women with diabetes can have perfectly healthy, wonderful, great pregnancies with no problems, but it's incredibly important that the blood sugars are under great control at the time of conception, before you become pregnant, in that first trimester when the baby is forming, to prevent birth defects. So if you're planning a pregnancy, please, please, please bring that up with your physician prior to becoming pregnant so that we can assure healthy pregnancy. And lastly, insurance. Nobody likes talking about insurance. It's really one of the most difficult conversations. It's way more fun to talk about what causes diabetes. But insurance is actually a really important conversation for you to have with your physician. One thing that you have to understand is that insurance coverage is often mandated by laws, and so to understand what will and won't be covered in some ways, it's useful to understand what's the law of your state. And I have no idea what's going on in other countries around this, so for our international guests, I apologize, I don't know the answers. But here in Michigan, there is mandated coverage for both diabetes education and diabetes testing supplies. However, how that's interpreted by different insurance companies is very important to understand. I frequently have patients coming to me and saying, I'm not testing because I took a prescription to my pharmacy and they told me I don't have coverage. Well, that's actually not true. It's mandated in this state. But the issue is, how do you get your supplies? How do you get your education? And what will it cost you are the questions you need to understand. Here in Michigan, about 80% of diabetes testing supplies has to be obtained through a durable medical equipment company and not through a pharmacy. So if you take a prescription to a pharmacy, the pharmacy will run your insurance and say, you don't have coverage. And it's not necessarily that they're lying to you, it's that you don't have pharmacy benefit coverage. You have it under durable medical equipment coverage. So if you are trying to figure out where you're supposed to get your testing supplies from, the first thing to do is call your insurance and ask them to clarify how you have your benefits for diabetes testing supplies. They will tell you it's either a DME, a durable medical equipment company, or it's a pharmacy. Once you have that figured out, then the next step is to figure out what it will cost you. And there are different kinds of insurance, and this really is so complicated. There's insurance that causes a copay. In other words, I always pay the same amount for this medication. It's just a set amount for any medication that you have to pay for with this company. So in other words, when I go see my physician, I have a $20 copay for the visit. When I go pick up my prescription for something, I have a $5 copay for the medication. Another way that this can work is a coinsurance, where you're paying a percentage. And if you're paying a percentage, the more expensive the medication or the treatment, the higher the cost, because it's a percentage. A third way that this works, and something that is very common here in Michigan right now, is what's called a high deductible plan, where you're paid 100% of everything until you meet a $1,000 to $5,000 mark. And so understanding how your insurance works and what costs you have under insurance is extremely important. Diabetes is expensive, and trying to navigate this is complicated. So understanding how to navigate it and working with your doctor and the resources your doctor has for you to help you navigate these issues is very important. So be proactive about this. Don't be embarrassed if you're having trouble figuring it out or affording medications. Talk to your physician about it. So in summary, diabetes is an elevation of blood glucose to harmful levels due to insufficient insulin to process the supply of glucose. Pancreatic diabetes is unique, common, but often not recognized. Many different pancreatic disorders cause diabetes. Talk to your doctor about the symptoms you're having and your specific risk for complications. Ask for a referral to an RD-CDE with experience treating patients with malabsorption syndromes. Monitoring is important, especially if you are ill. In answer to the famous question, do all patients with pancreatic diabetes need insulin? No, not all people with diabetes need insulin. Not all people with pancreatic type 3C diabetes need insulin, but insulin is absolutely required if a person does not make any insulin at all. Even if they make some insulin, it may still be the best treatment. Ask your doctor which treatment is right for you. If you do require frequent insulin injections, consider an insulin pump. Understand your risks for alcohol. If you're a young woman who's planning a pregnancy, please make sure to plan your pregnancies with your doctor and ask for help navigating insurance and costs, and have a diabetes checklist so that you can keep track of all the things that you need to be keeping track of. I hope it's been a helpful presentation. Thank you so much for your time.
Thank you very much, Jen. If you wouldn't mind staying at the podium, during the next section, we are going to do our panel discussion. The way this is going to unfold is that Dr. Wyckoff is going to answer a series of questions that have been posted online, and then this will be followed by Dr. Wamsteker doing the same thing. We're going to take 20 minutes, and so we'll end the panel discussion at 11:45 Eastern Time. We'll take about a 5-minute intermission, so that'll put us about 5 minutes behind the stated schedule that you have on the flyers that were sent out, and then we'll move on to the second half of the program. So without further ado, Dr. Wyckoff, I look forward to hearing your answers to these questions.
Okay, thank you. Okay, so one of the first questions that was sent in was, I have chronic pancreatitis. My endocrinologist diagnosed me with type 2 diabetes. How do I know if I have type 2 rather than type 3C? So it's complicated. The long answer is your physician will take a look at you and figure out, are you losing weight? Are you gaining weight? Do you have evidence of exocrine pancreatic insufficiency, etc.? The lab test that we most commonly do is what's called a C-peptide. A C-peptide is a breakdown product of insulin, and it is a very good way of us understanding how much insulin a person produces. So in type 2 diabetes, at least early in type 2 diabetes, you typically see very high levels of C-peptide, indicating that the pancreas is working very hard to try to control and overcome insulin resistance. So in a person who has very high levels of C-peptide, that is almost assuredly type 2 diabetes. But in many patients who have late-stage type 2 diabetes, in all patients with type 1 diabetes, and in patients who have fairly progressed with their type 3C diabetes, you'll see a low C-peptide, indicating little or no insulin production. And so I tend to test that when I'm trying to understand the difference between type 2 and type 3C diabetes. If I have a patient who has terrible steatorrhea, clear exocrine pancreatic insufficiency, they're losing weight, they obviously are insulin deficient on exam, I won't check a C-peptide. I know they have type 3C diabetes. But in that first example, the overweight man with hemochromatosis, that would have been a patient where I would have checked a C-peptide to try to really understand what was going on with his physiology. I hope I answered that question. Is it normal for blood sugar to fluctuate with chronic pancreatitis? It is normal for blood sugar to fluctuate with absolutely everything. So you see fluctuations in someone who does not have diabetes around a very tight set point, because the pancreas and the liver are all working well, and they're all paying attention to what's going on with the blood sugar. So if you have someone who does not have diabetes, they may wake up in the morning with a blood sugar of 60, which is actually normal for, thin, college-age, young, healthy adults. And then, they eat a pizza and a hot fudge sundae, and their blood sugar might go up to 98, maybe 102. And that level of fluctuation is normal in somebody without diabetes. In people with early type 2 diabetes, you start to see more variability, specifically with spikes after meals, usually. Often the pancreas responds to different signals from the body. It responds to gut hormone signals. It also responds to actually what the blood sugar is. And as its ability to respond to those signals becomes more and more impaired, you will see more and more fluctuation with eating, with exercise, with stress, with pain, etc. So type 2 diabetes patients tend to have less fluctuation on average than patients with type 3C diabetes. Type 3C diabetes usually has far more fluctuation than type 2, but actually the greatest fluctuation is seen in type 1. The reason for that is that patients with type 1 diabetes, while they make no insulin, still make a lot of glucagon. So they can have really robust swings. So there's a lot of issues going on with type 1 having the most brittle diabetes out there. But you certainly can see very brittle diabetes with type 3C. And so yes, it is common for blood sugars to fluctuate with everything, but when you're having bouts of chronic pancreatitis, where you're having pain, variable food absorption, variable insulin production, variable insulin resistance, you can certainly see quite a lot of change. Actually, the cystic fibrosis population is one of the groups that is most known for its ability to fluctuate in their blood sugar control over time. Is annual A1C level recommended to diagnose diabetes and to monitor control of blood sugar? That's actually two different questions. The United States Preventive Services Task Force recommends that everybody, I think over the age of 40, every adult be screened for diabetes annually. So that would be an A1C for basically anybody over 40 annually. It's recommended to be screened at earlier ages using an A1C if you have risk factors, strong family history, polycystic ovarian syndrome, history of gestational diabetes, etc. A1C is not the only way to diagnose diabetes, and in cystic fibrosis, the cystic fibrosis population recommendations are actually for oral glucose tolerance testing, as it's found to be far more accurate for that population than A1C. The second part of that question, to monitor control of blood glucose, actually we recommend an A1C every 3 to 6 months for monitoring control of blood sugar in patients with established diabetes. What are common symptoms of diabetes? The classic symptoms of developing diabetes are what we call the polys: Polyuria, in other words, you're urinating a lot, especially at night, more than normal. Polydipsia, you're very thirsty because you're urinating so much. The high blood sugar acts like a diuretic. It pulls water out of you. So you're really thirsty and you're urinating all the time. Many people also develop blurred vision because high blood sugar causes swelling in the eye. So a pretty common presentation is for someone to say, my golf game is off because I can't see where my golf ball's going. So those are some of the classic presentations. As diabetes becomes more severe and the level of the hyperglycemia is worse, those patients can present with nausea, vomiting, confusion, and be really quite ill. So the early symptoms are the polys, the polyuria, the urinating a lot, and the polydipsia, the drinking a lot, blurred vision. Later symptoms of more severe presentations tend to be quite ill. But the truth is, many people with diabetes will have diabetes for years before they are actually diagnosed. Early diabetes is asymptomatic. Is it true that blood sugar becomes harder to control when the pancreas becomes more damaged? As you've probably already figured out about me, I can talk forever about diabetes, so I'm going to give you the short answer. Yes, it does become harder to control as the pancreas becomes more damaged. Next question, are there diets that can prevent diabetes and get the pancreas working again? Well, those are two different questions. So in type 2 diabetes, we know that diet is incredibly helpful at delaying or preventing the diagnosis of diabetes. The Diabetes Prevention Program, which was a study of diet and exercise versus nothing to see if diabetes could be prevented, showed a 60% reduction in the progression from prediabetes to diabetes for patients who did two things: lost 7% of their body weight and exercised at least 150 minutes a week of aerobic exercise. So it is true that diet is incredibly important, and exercise is incredibly important in helping prevent the progression to type 2 diabetes. Is that true in type 3C diabetes? And the answer is, well, I don't think anyone's ever done the study. And it's probably not, because a lot of the progression to diabetes in type 3C diabetes has to do with the underlying pancreatic disease and not the insulin resistance related to obesity. Now, is that completely true? No. That first patient I discussed who had hemochromatosis, he may have really benefited from a diet that helped him lose weight. That could have helped prevent or delay his diagnosis of diabetes. But for patients who've had pancreatectomies, for example, or who have had chronic pancreatitis over the years, classic weight loss, which has been shown to be helpful for patients with type 2 diabetes or pre-type 2 diabetes, may not actually be beneficial in this situation. However, that does not mean that diet isn't important. Diet can definitely impact your GI symptoms and help you have fewer GI symptoms and help you have better control of your diabetes. But I'm not sure that it's going to prevent diabetes for the majority of people who are destined to develop type 3C diabetes. Can it get the pancreas working again? I know of no data on that. That would be perhaps a question for the gastroenterologists on the panel. I have no data that there is a diet that can get the pancreas to work again. So does insulin cause blood sugar levels to vary a lot? So that's a really good question. And people have over the years observed that patients on insulin tend to have greater swings in their blood sugars than people who aren't. But this is really not a chicken and an egg story. People who need the insulin because they have no insulin production or very little insulin production of their own. And so they tend to have more variable blood sugars. And it's the disease process that's causing the blood glucose variability, not the insulin. And then please explain islet transplant and its benefits to patients. So there are both pancreas and islet transplant technologies that have been developed. Pancreatic transplant is when an entire pancreas is transplanted, and that restores beta cell function and patients make insulin again. So that is a sort of known procedure. It is performed. Primarily, it is reserved for people who already are having solid organ transplants of other forms, because the transplant medication you need to keep the pancreas from rejecting is quite toxic in its own right. And so the risk-benefit ratio is not there for most patients. So pancreatic transplants is not something we do typically. It would be something that you should discuss with your doctor, ask if it's something that would be right for you, but it's truly not something that is very commonly done because the risks associated with the surgery, and specifically the immunosuppression after the surgery, are not insubstantial. Islet transplant is not something that is done as part of normal clinical practice. That is an experimental procedure. Islet transplant is where you take basically a slurry, a ground up cocktail of islet cells from donor pancreases and infuse them into the liver where hopefully they will stick and start to make insulin. Islet cell transplants are only in the experimental version. They're not typically done for patients. Both pancreatic and islet transplants can help people make their diabetes go away, usually not for very long. I don't have the exact data for how many years each type of protocol has gone, but in general, they're not very often performed. What can I do to decrease the likelihood of getting adult onset diabetes? I already answered that one with the information on the diabetes prevention program. Diet and exercise are hugely helpful in this area. And then I loved this question, thank you to whoever asked it. Is my type 1.5 diabetes result of immunotherapy the potential cause of further pancreatic problems? And are you aware of others whose diabetes is the result of cancer treatment? So this is actually a fascinating story. So patients who are treated with some of the newer biologics for cancer, ipilimumab was one of the first. The way these drugs work is they put your immune system on hyperdrive. They're trying to get your immune system jazzed up to take on whatever cancer a person has. And they're very effective. The melanoma data is absolutely amazing for some patients. But they have this interesting side effect in that when they get your immune system jazzed up to take on the cancer, it also tends to take out other endocrine organs that just happen to be in the way. So you see a very high rate of autoimmune thyroid disease, autoimmune pituitary disease, autoimmune diabetes with patients on some of these biologics. And so if you are thinking about taking a biologic, you should know that this is a potential risk factor. But it is a misnomer to call that type 1.5 diabetes, because that truly is type 1 diabetes. It's an autoimmune attack on the pancreas. What is interesting about it is that that autoimmune attack, unlike in traditional type 1 diabetes, is not always as sustained. So some people will actually not end up having complete loss of all insulin production when their type 1 diabetes has been caused by an immunotherapy. But as I said, the differential diagnosis of diabetes is fascinating. And I'm actually, for the sake of time, going to miss the last question. I do apologize, but I'm getting waved at for talking too much. So thank you again for your time. I appreciate the opportunity to speak to you.
Thank you very much, Jen, for that those wonderful answers to the series of questions, and thank you for the questions that were submitted online. We're next going to turn to Dr. Wamsteker, who's going to take about 5 minutes or so to answer some additional questions that were also submitted by our attendees.
So what type of diabetes is caused by having a pancreatic surgery called the Whipple procedure? That would fall into the category of type 3C diabetes, and in theory can occur from any type of pancreatic surgery. A Whipple procedure or a distal pancreatectomy, which are probably the two most common resection procedures, are not always associated with post-op diabetes, although it may depend somewhat on the distribution of islet cells that there may be more that are in the head of the pancreas or in the body or tail, and so that may affect the potential development of diabetes post-operatively. But the direct question or direct answer is that that would fall, if you develop diabetes post-op, it would be type 3C diabetes. And question 2 is, what is the average age of onset of diabetes in people with chronic pancreatitis? This somewhat depends on the actual etiology of their chronic pancreatitis. So in patients that have hereditary forms where the disease may develop in childhood, they may be more prone to developing diabetes at an earlier age than perhaps patients that have an acquired form of chronic pancreatitis, which may occur later on in life. So it may not be that easy for me to give you a direct answer of a specific average age. It's really going to depend on the specific etiology of their chronic pancreatitis. And question 3 is, do my chances of becoming diabetic increase with the number of attacks of pancreatitis? The answer is probably yes, and that has more to do with the likelihood that if patients have very frequent attacks of acute pancreatitis, they're more likely to go on to develop chronic pancreatitis. And of course, that's the most common cause of type 3 diabetes, or type 3C diabetes. And then question 4 is, what is the typical progression from diagnosis of chronic pancreatitis until diabetes appears? I can't tell you a specific time frame for when diabetes will develop, but long duration of chronic pancreatitis is associated with the high likelihood of the development of diabetes. Upwards around 80% of patients or greater with chronic pancreatitis will develop diabetes sometime within 25 years of their original diagnosis. And again, there may be some unique things about when a patient's more likely to develop diabetes in the setting of chronic pancreatitis, such as whether they have specific complications that occur as a result of their unique individual disease. The next set of questions has more to do with exocrine pancreatic insufficiency. The first question is, does pancreatic insufficiency mean you have chronic pancreatitis, or can you have pancreatic insufficiency without having pancreatitis? The answer is that pancreatic insufficiency can occur in other disease processes that affect the intestine. One of the more common causes of pancreatic insufficiency is actually beyond chronic pancreatitis would be surgery. So surgery that diverts the pancreatic and biliary secretions away from food stream, such as a Whipple or bariatric surgery, can institute some degree of pancreatic insufficiency, which can be treated with digestive enzymes as indicated. Question number 2 on this page is how helpful are pancreatic digestive enzymes? I would say that they're very helpful if patients have documented pancreatic exocrine insufficiency, and when the doses of that, when the digestive enzymes that are being applied are appropriately dosed. In patients that have documented pancreatic exocrine insufficiency who are on digestive enzymes don't improve or have a relapse of symptoms, that may be indicative of a concomitant digestive disorder such as small intestinal bacterial overgrowth. And of course, if patients are on pancreatic digestive enzymes, they should be monitored by their physicians for these types of symptoms. Question 3 is, how do you know if pancreatic digestive enzymes are working for you? Well, it depends on whether you went into treatment with classical symptoms of malabsorption, such as gas bloating and or diarrhea. And so a lot of these symptoms may improve or resolve with appropriate doses of digestive enzymes. Your physician may monitor you for nutrient deficiencies, fat-soluble nutrient deficiencies, which may also be an objective way of assessing whether a patient's responding to pancreatic enzymes appropriately. And what is the consequence of not taking pancreatic enzymes? Again, the purpose of the digestive enzymes are not only to relieve digestive symptoms that result from pancreatic exocrine insufficiency, but also to ensure appropriate absorption of nutrients, in particular fat-soluble vitamins. And so there can be consequences of bleeding disorders that can result. There are cardiac problems. There's other digestive problems such as osteoporosis that are fairly common complications in patients that are not appropriately taking digestive enzymes in the setting of pancreatic exocrine insufficiency. That being said, I'm getting the proverbial hook from.
Well, thank you very much, Dr. Wamsteker. At this point, I'd like to thank all of our speakers from our morning session on diabetes, and in particular, Dr. Wyckoff, our keynote speaker, and Dr. Wamsteker for spending the time answering all these excellent questions submitted by the online attendees. We'll break now, go to intermission, and we'll see you shortly. Welcome back. Intermission is concluded. We are going to begin the second half of the program, the fourth annual Patient and Family-Centered Care for Pancreatic Diseases, focusing on pain in pancreatic diseases. My disclosures are to AbbVie as a consultant, work on a campaign to raise awareness for exocrine pancreatic insufficiency. The learning objectives for my introductory talk on pain are the following: recognize general causes of abdominal pain and pain associated with pancreatic disease. Secondly, to understand how organs and the nervous system cause pain. Third, to review how nerve pain responds poorly to interventions in some situations, and to highlight how non-interventional therapies for pain. This diagram gives you an idea about abdominal pain arising from other organs within the abdomen neighboring the pancreas. In the top left, the liver. On the middle left, the gallbladder and bile duct. Pain may arise from gallstones or blockage of bile ducts. In the lower left, the small intestine, which encircles the pancreas. Pain may arise from ulcer or blockages. In the top right, the stomach. Pain may arise from ulcers or slow stomach emptying or hypersensitivity. And then the spleen in the far right. Other causes of pain, there are multiple. A few listed in the lower right, including low blood flow to the bowel, or kidney stones, or abdominal pain. In the bottom, the pancreas, the structure behind the stomach and encircled by the duodenum. That'll be the focus of our next slide. Now, pain is poorly understood in chronic pancreatitis. This diagram depicts three proposed pain mechanisms in chronic pancreatitis. There are various anatomic causes I will highlight, and then two types of nerve-related pain. In terms of anatomic causes, on the far left, there can be blockage of the bile duct, blockage of the small intestine causing pain. In the top, increased pressure within the pancreas, either in the tissue or within the duct, or pressure exerted from an inflammatory collection or cyst. In the middle, at the bottom, recurrent bouts of acute inflammation can also cause pain. Now, several of these, particularly obstruction, can be targets for interventions, surgery, endoscopic drainage. The lower right are the two different nerve-related pains. Nerve-related inflammation. This picture shows inflammation involving the nerve sheath. And then on the far right, altered pain processing by the brain. Pain is a hallmark symptom in chronic pancreatitis, but not all people develop pain. It can be absent. It is typically in the upper abdomen, radiating to the back as depicted on the far right. Typically, attacks are intermittent and short, but constant pain, when present, may be attributable to local anatomic causes, those of which I just reviewed on the last slide, and again, may be targets for intervention, surgery, endoscopy, drainage, but also constant pain may arise from non-anatomic causes or nerve pain due to visceral hyperalgesia or hypersensitivity to pain, which may arise as an adaptation to chronic pain over years or chronic opioid use. And secondly, centralization of pain. This is analogous to a phantom limb pain. With these understandings of nerve-related pain, this may explain why pain may persist in up to 40% of patients who have undergone total pancreatectomy, and why there may be a poor response to interventions such as surgery or endoscopy in those who've had long-term pain, 2.5 to 3 years, or are using chronic opioid use for analgesia. Confusing but true, the presence of pancreatic abdominal pain cannot be reliably predicted based on how severe or mild the pancreas appears on CAT scan or other imaging modalities. There is a disconnect. In current clinical practice of treating abdominal pain associated with chronic pancreatitis, there has been, at least historically, an overuse of treatments aimed at acute tissue pain by use of opioids, injections, surgery, endoscopy, and infrequent treatment aimed at pain signaling through the nerves. There are a variety of options in terms of pain, neural modulation. Just in brief, medications falling under the category of antidepressants, tricyclics, SNRIs, gabapentinoids. There is a randomized controlled trial demonstrating this proof of principle concept and showing shortening of fewer painful days a month with treatment in patients with painful chronic pancreatitis. Cannabinoids, this is a question mark. This is the focus of Dr. Wiley's research presentation to follow. There are also non-pharmacologic therapies that have been used in other chronic pain disorders, which may also have value. There have been 2 trials of acupuncture in chronic pancreatitis. The more recent trial shows that there appears to be provide short-term pain relief less than 1 week, which may be valuable for some people. Potentially effective, but understudied in chronic pancreatitis are behavioral therapies. This is going to be the focus of Dr. Riehl's keynote speech. I am going to leave the details to her. So with that introduction to pain, we are going to next move on to our patient testimony. This is Georgiann Ziegler. She is, as Dr. Wamsteker pointed out, not able to attend today due to illness. She is a board member for the National Pancreas Foundation. She serves as a patient advisor on numerous committees and boards at Michigan Medicine, all aimed at improving the lives and experiences of patients. She has agreed to share with us her journey with pancreatic disease, and in particular with this part of the program, pain.
I talked about diabetes, and now I want to share about pain, pain management, and the different ways to get through pain. So obviously, pain is something I know very well. For me, I have chronic pancreatitis, but I do not have chronic pain. My good days are good, like today. So I don't consider myself a chronic pain, but when I do get the pain, it's at the onset of a flare. And for me, it begins with a full feeling in the upper abdomen, like someone has their fist there, distension of the abdomen. And at that point, I try to take away all intake of food and liquid. And sometimes I can turn that pain around, and sometimes I can't. And the next step in the pain would be a dull, achy pain in that same area that leads to more of a sharp pain. And at that point, sometimes a heating pad, sometimes just changing position will give some relief, along with not taking in much orally food or drink. For me, the next phase would be that the pain starts to get stronger. And at that point, it might be that, that heating pad might be used more often, or really trying to change positions. And as the pain starts to become much more sharp, then of course, pain medications that have been prescribed by my doctor usually help. But I know at that point, as it radiates through to the back, the pain, then I'm looking at a trip to the emergency department. That all being said, I have found that when the health system has mentioned to me, health professionals have mentioned to me, you know, you need to try some other things for pain, you begin to say, well, wait a minute, this hurts. What do you mean other things? But I have found their suggestions of a heat pad, heat packs and heating pads and things of that nature have really helped. It may not take away the pain, but it makes it much more comfortable. The breathing through the nose and out the mouth, I don't know so much if it helps the pain, but you're spending so much time thinking, close your mouth, breathe through your nose, open your mouth, exhale, that it takes away the thought process of the pain. So I will say to that, you know, be open to other treatments for pain, because what happens is when you do that, it's not minimizing your pain, and it's not that people are not believing you are in pain, but they are trying to help you cope with the pain that you're in to either get you to the emergency department or get you through the pain, so hopefully you won't even have to go. I would say just be very open with the alternative methods to pain control. That being said, you know, I think our healthcare providers realize the pain that we are in, and we are in pain. But some of these alternative methods will get us through to whether we need to go to the emergency departments, make appointments with our physicians, or just ride it out. And if we can find ways to find some comfort, I think that's a big help for all of us.
Thank you, Georgiann. That was a wonderful depiction of your life's journey, as well as the symptoms to illustrate pain in chronic pancreatitis. We are now going to move on to our research talk. This is Professor John Wiley from the Division of Gastroenterology at Michigan Medicine. He's been on faculty since 1987. His clinical focus is the gut-brain axis, gastrointestinal motility disorders with a particular interest in irritable bowel syndrome, diabetes, and the effects of aging in the GI tract. He has been well funded from the NIH, focusing on pain mechanisms, including endocannabinoids and cannabis, on neurotransmitter regulation of ion channels in health and disease. He served in numerous leadership roles in Michigan Medicine and nationally, including the American Gastroenterological Association. With further ado, John, welcome.
Thank you, Matt. I want to thank you and your team of organizers for the opportunity to share some thoughts about this very important topic. My goal is to basically review some of the clinical literature that is relevant to pain and the use of cannabis, and particularly focusing on pancreatitis, but also other pancreatic disorders, but it'll bridge into some other uses of cannabis. But I'm going to be focusing not so much on the weeds, bad pun intended, of the use of cannabis, but what we actually do know from the available literature. As you'll see, it's still a very open question about where cannabis may best be applied and what kind of combinations with other medications will be helpful. So I want to start just by introducing you a little bit to a system in the body called the endocannabinoid system. This is a ubiquitous system. It's present everywhere in the body. Many of you probably do know that we, in fact, make our own cannabis-like compounds, molecules in the body. They're called endocannabinoids. We've known that for actually centuries because people have been using cannabis products in terms of plant products for centuries, and it's well documented in medical lore about their effectiveness in a variety of different situations. But we didn't know until fairly recently, and indeed in the last probably 2 decades, we had not the ability to measure these compounds. But now we do, and we have a better understanding of what makes them, those enzymes that produce these endocannabinoids, as well as the enzymes that break them down. I emphasize that because these are the targets of the next generation of medications and therapeutic interventions that will enhance the endocannabinoid system and or help inhibit its breakdown, because in general, these endocannabinoids appear to have a benefit in both inflammatory conditions and some other conditions, which I'll allude to. The major receptors that they work on are the so-called endocannabinoid 1 and 2 receptors. Again, these are present everywhere in the body. The number 1 receptor primarily on neural systems, the number 2 receptor on non-neural systems. And so it plays a lot of, just a huge role. Very, very well robustly expressed in the brain, particularly in affective areas. So mood disorders, anxiety, stress-related responses are very much involved in how we respond with the endocannabinoid system. So I'm going to move now to cover what we do know about clinical trials in this area. THC, as you know, is the abbreviation for tetrahydrocannabinol. This is the active ingredient in the plant product of cannabis sativa. We also have a medication that is synthetic based on the structure of THC, and that's called Marinol or dronabinol, which we used in the clinical setting. The advantage of that is we know exactly how much we're giving a patient in terms of having a synthetic product. One of the disadvantages of the cannabis products is that we don't know exactly how much of the good stuff is in these plants. And it could vary from lot to lot, as many people know. And we're really very much at the mercy of the people that distribute these things in terms of what they believe is the active, how much of the active ingredient is present in the cannabis products. So in the first study I'll mention is done back in 17 or reported 17, and they looked at the THC and does it reduce pain in patients with chronic abdominal pain. In a phase 2 trial, this means there was a control group, which is absolutely critical for this kind of research. And the issue there is that the so-called placebo effect, if you're studying pain, can be as high as 30 to 40%. So you really need to understand that when you're designing these trials and make sure that you have adequate controls if you're going to do it in a randomized control fashion. In the second study, a single dose of THC in chronic pancreatitis patients, looking at analgesic efficacies and pharmacokinetics, which means how it's broken down and how it's tolerated, meaning side effects, a single dose of THC was not effective in reducing chronic pain resulting from chronic pancreatitis. In another study, cannabinoid receptor agonist, this is another product that attaches to and mimics the actions of THC, did not have effects on the cytokine levels. These are these pro-inflammation molecules that are generated in the scenario of chronic pancreatitis. And so it was hoped maybe they would see that the use of a cannabis product or THC would help reduce these pro-inflammation molecules, but they did not observe that. So under the possible or maybe category, the effects of cannabis on the use of opioids in a hospital setting were studied. And here it looked like there may be an effective effect of cannabis as an adjunctive therapy. So in combination with other treatment modalities to help reduce the level of, for example, opioids that might be used to help treat the pain. So this study was limited by the small sample sizes, but it does serve as an important platform that future studies could focus on. Is there a role for cannabis products as adjunctive treatments in the management of pain in this difficult scenario of chronic pancreatitis and pancreatic pain? It's also been looked at whether cannabis is effective in cancer-related pain. There was a large meta-analysis, which means people went and they put together all the data from a number of different studies that added up to about 1,442 adults. And they compared cannabinoids to a placebo. So again, that's important. And other active agents for the treatment of cancer-associated pain. And unfortunately, there was no significant impact on the cancer-associated pain. Now, cancer has other things going on, obviously. There's other molecules being generated. And that makes it's not exactly an analogous situation to chronic pancreatitis. There was some side effects with the cannabis products in terms of sleepiness and dizziness. In my view, this study was a little bit limited. They could have included some more clinical trials that I was able to identify that were not included. They have reasons to exclude certain kinds of clinical trials if they did not meet their standards of quality control. And unfortunately, because it's a cancer-related research project, it includes cancers of multiple different types, and they may not be similar in terms of comparisons. So next we'll look at the therapeutic effects of cannabis and cannabinoids, and this was an update where a very important paper that came out by the National Academies of Sciences, Engineering, and Medicine in 2018. And this was a 16-member committee that conducted a large review of a database that included 10,000 abstracts to look at in terms of benefits. And the summary was there was conclusive or substantive evidence for effective treatment of pain, in this case neuropathic pain, and I'm talking neuropathic pain to contrast it to what in general we call non-neuropathic pain. This would be an example of acute pain. For example, you stubbed your toe or dropped something on your foot, or your hand got pinched in a door. That's acute pain. Neuropathic pain tends to be defined as chronic pain. And this could be caused by a number of different neurodegenerative processes, infections, or other things that leave one with chronic pain over time. So chronicity is important here if you're trying to distinguish acute pain versus neuropathic pain. So the effective treatment of pain included neuropathic pain in adults, chemotherapy-induced nausea and vomiting. I can come back to that in terms of some of the questions, because I think cannabis does have a role for management of and certainly Marinol and some of these other synthetics for the management of nausea. Perhaps not been compared yet for, it might have a bit better effect on that endpoint of nausea than it does on pain. And spasticity associated with multiple sclerosis. There was moderate evidence for secondary sleep disorders and limited or insufficient evidence supporting improvement in appetite, because we all know about cannabis and the reported anecdotal stuff on munchies. A lot of people would say, yep, it's absolutely true, but it's hard to, it has not been established exactly how that pathway works. Tourette's syndrome, anxiety, post-traumatic stress disorder. They mentioned cancer here. It was one particular kind of cancer. Irritable bowel syndrome, epilepsy, and a variety of neurodegenerative diseases. We just need more data. We need more of those controlled trials, which in fact are beginning to come out now with the increased use of cannabis products. So then there's this other product out there that has broad interest nowadays, and that's cannabidiol. Cannabidiol is also part of the cannabis product. The cannabis product and THC work primarily on the so-called CB1 and CB2 receptors. They have high affinity, and their downstream pathways after they activate those receptors is a pretty active area of investigation. Cannabidiol is also present in the products that are available now. They tend to be very high in THC and relatively low in cannabidiol. This is just a matter of how they're, what the people are raising these are trying to enhance the THC, and as a byproduct of that, engineering, we'll call it, plant engineering, they're seeing less levels of cannabidiol, but cannabidiol is very high in hemp. It's a very active area of research. It probably works through a different mechanism. The best thinking that I can see out there is that cannabidiol works by inhibiting the enzymes that break down the endocannabinoid substances, these naturally occurring substances. And thereby you see an elevation in the endocannabinoid products, and they're doing their anti-inflammatory and anti-pain and anti-nausea types of effects through that mechanism. So inhibiting the enzymes that break it down raises the levels of the endogenous product. There's only one FDA-approved cannabidiol product, that's called Epidiolex. This was developed in treatment of childhood seizure disorders, which it is effective for. This raises the issue again of the reason why this is such an important thing to have available is that we know exactly how much cannabidiol is in this product, where if we're just getting it off the shelf, we do not know exactly how much of the cannabidiol is in those products because they're typically not measured. In a few cases they are, but typically not. It is effective for controlling these seizures, childhood seizure disorders, which I identified in the middle here. Acute cannabidiol dosing before anxiety-provoking events such as public speaking and the chronic use of CBD or cannabidiol in schizophrenia are promising but unproven. So it's not risk-free. The beauty or the advantage of cannabidiol is it has less psychotropic effects. In fact, it's very hard to really demonstrate it has any psychotropic, central nervous system psychotropic effects, so that's good. But it does have some somnolence and some other side effects associated with it. These are the side effects that I think I've been asked to address these through questions. So there's the psychotropic, psychedelic effects, euphoria, hyperactivity, hallucinations. There's gastrointestinal side effects, the mouth dryness, anorexia, and nausea. And then the CNS is a variety of things which are outlined here on the lower left. But primarily it's drowsiness, fatigue, and tiredness, and musculoskeletal myalgias, and some muscle weakness. So where are we headed? I think the direction is going to be, and this is actively being researched right now, specific receptor agonists and antagonists and modulators of the synthesis and breakdown or degradation of the pathways that the endocannabinoid system works are very active areas of research. Targeted, specific CB1, CB2 compounds that act specifically on those receptor subtypes is an active area of research. The role in chronic pancreatitis is still equivocal. The sample sizes need to be increased. And we need to understand better why some people respond and some people don't. The working hypothesis on that particular situation is that some people seem to downregulate the receptors that these endocannabinoids and the plant products work on more quickly than others, and so they get less benefit over time. There's other situations where it's thought that we all metabolize these compounds differently. That's called pharmacogenomics. That's thank you, Mom and Dad. We kind of inherit that, but it's also regulatable by environmental influences. So there's a big gap in our knowledge of how we break down these substances, and that we may do it differently as individuals. So the next generation of therapy is going to have to be more personalized. We're going to need to know who's at risk and who may benefit more. And there are some interesting new receptors that are coming out that as potential targets. I'll stop there, and thank you.
Thank you, John, Dr. Wiley, for that wonderful research talk that was requested by last year's attendees to our meeting. We're going to move on now to our keynote speaker for the second portion of our program, Dr. Megan Riehl, who is an assistant professor of internal medicine, Division of Gastroenterology here at the University of Michigan. She is a GI psychologist who specializes in the treatment of GI problems and anxiety-related disorders. She's also the clinical director of the GI behavioral program at the University of Michigan. Extramurally, she is the director of behavioral health services and support for GastroGirl, Inc. and GI On Demand. She's the co-chair for the Rome Foundation Psychogastroenterology Education and Training Committees. She also sits on the membership and mentorship committee of the American Neurogastroenterology and Motility Society. Welcome, Megan.
Thank you, Dr. DiMagno, for including me in today's presentation, and that was really interesting, Dr. Wiley, so thank you for sharing your expertise. Today I'll be talking about behavioral therapy and really integrating it into your care in chronic pancreatitis. These are my disclosures. So the way we treat different medical conditions today is really starting to change. It used to be that you would have a doctor in one location and then another doctor and another doctor, but they wouldn't really communicate the way that now we're learning is so beneficial in our care. So this idea of medical silos really has to change, and these silos need to kind of crumble and come down. We're seeing the benefits of this now in research as well, as I'll show you in a couple slides. The reason why we need multiple providers, such as a psychologist included in your care, is because of the complexity and really the multifactorial nature in which you're impacted. So with about 50 out of 100,000 people being impacted by chronic pancreatitis, there's also lots of different ways in which you may be impacted by this disease. Alcoholic, idiopathic, hereditary, obstructive, hyperlipidemia are some of the traditional classifications. Abdominal pain is very common. And about 75% of patients present initially with abdominal pain. And it can be described, as Dr. DiMagno shared, as dull, sharp, or nagging sensations in the upper abdomen. They can radiate toward the back, and that it can be exacerbated by food. And this is very common among many of the GI patients that I see with irritable bowel syndrome and inflammatory bowel disease. And while there's still not much literature, and really there's a dearth of information that we don't know about the application of behavioral health to patients with pancreatic diseases, we can translate many of the things that do work from some of the other gastrointestinal conditions and apply them to many of the symptoms that patients with chronic pancreatitis experience. So this study was in The Lancet, just came out in July of this year. And I really look at it as a landmark study that's going to move our field ahead. And it compared two different models with gastroenterologist care only, though that provider did have the opportunity to refer patients out to other specialists if needed or if wanted. But then more of a multidisciplinary clinic that's very similar to what we offer at Michigan Medicine that included the gastroenterologist, psychologists, dietitians, behavioral physiotherapists, and psychiatrists. And what this study indicated was that when we looked at successful outcomes, which were less GI symptoms and greater improvement in overall psychological well-being, the multidisciplinary clinic was far superior. And so I think this really highlights this transition that it's not up to one provider anymore to improve your health. It really is going to take a team. And not only did it help to improve the health of patients, but it also reduced healthcare utilization costs. So at Michigan Medicine, I came to the U in 2014 to begin our behavioral health program. And we've really grown since then to include another GI psychologist, as well as we have several GI trained dietitians. Our patients have access to pelvic floor physical therapists, and really we are a model for integrative multidisciplinary care. In our GI psychology service, myself and Dr. Christina Jagelski, we are both doctoral trained clinical health psychologists with specialization in gastroenterology, meaning that we have additional extensive training in different medical conditions, and how we apply psychogastroenterology principles to the management of your GI condition. So if you all were sitting here in the room with me, I would ask you to raise your hand if you had ever heard of the term psychogastroenterology. And it's somewhat of a newer term, though the field has been around for quite a while. But what psychogastroenterology highlights is that at the center is you, the patient. And then we utilize different evidence-based psychological interventions to help you best manage a digestive condition. We are part of a collaborative, integrative care team. So we never want our patients to feel like, maybe your disease is well controlled at this point, but you're still experiencing pain, or that your physician doesn't have anything further to offer you for pain, so maybe some of your pain is in your head. We're not here to say your pain is in your head. We're here to help you understand the nuances of that pain, as Dr. DiMagno and Dr. Wiley talked about, and provide you with different psychological therapies that have been found to be helpful. So many of the patients that I see experience what's called visceral pain, and this is pain that's driven by sensations in the nerves of your gut and your stomach, and that those nerves send signals up to your brain, and the brain really interprets those symptoms and signals, and then you get stuck in this cycle of feeling the pain more intensely. So this is a really excellent example of the pain is not in your head, but your head is involved, that your brain is really focused on those uncomfortable sensations, that the nerves are sending those signals up. And so we do see in chronic pancreatitis that there is overlap in some of the disorders of gut-brain interaction. That's a newer term that we use to describe functional GI symptoms or diagnoses such as irritable bowel syndrome. We see that there's some overlap in those patients, but also similar types of experiences with that pain. So when it comes to kind of managing pain, since it is quite challenging to treat, oftentimes we know that patients are prescribed opioids, and while that can be effective and necessary, the long-term use of opioids can become quite dangerous. Up to 25% of patients use opioids for non-medical use, and up to 40% of patients have opioid misuse concerns when it comes to chronic pancreatitis. So we want you to have additional options. We want you to recognize that there are other ways that we can manage pain, but there may also be other things that you're experiencing that is exacerbating your pain. So for example, untreated psychiatric diagnoses can actually make coping with the complexities of a diagnosis like chronic pancreatitis difficult, which may then make you feel your pain and or have less tolerance for your pain. Depression, which is common in chronic pancreatitis, also lowers your physical and psychological quality of life, which leads to an overall poor quality of life. And the more pain you experience, oftentimes the more you may isolate or remain, by yourself, or kind of isolating away from activities that could enhance your psychological well-being, but that you don't necessarily have kind of the coping strategies to mitigate how to manage the pain and also how to engage in your day-to-day life. So research, like as I've already said, we have a long way to go in chronic pancreatitis, but we do recognize that having this interprofessional treatment approach that incorporates surgical aspects, medical aspects, psychiatric specialty care, pain management, and behavioral therapy can all be a benefit for patients with chronic pancreatitis. Some of the best practices model really indicate that lower healthcare costs can be achieved by combining these models. So the behavioral approaches for pain management that I'll discuss in a couple minutes, psychological treatments to mitigate depression and anxiety. I always say that stress, depression, and anxiety will never make anything better. And so knowing that and knowing that there are treatment options for that can make a significant impact in your life. Behavioral management for opioid medication management is important. Psychotropic medication can be also helpful for pain as well as different mood symptoms. And then it's also important to incorporate our MD specialists in your standard medical and surgical treatments. So behavioral and psychological approaches to managing pain right now are underutilized in patients with chronic pancreatitis. But I'm hoping that in the next couple of slides I can persuade you why some of these psychological interventions may be important parts of your care that you may be missing out. Cognitive behavioral therapy, gut-directed hypnosis, mindfulness techniques, and acceptance and commitment therapy are common psychological strategies that we implement in patients with GI conditions, as well as other medical problems. And so many of the goals are to utilize these evidence-based strategies for improving your skills training for the management of pain. So the goal is not that your behavioral therapist is going to cure your chronic pancreatitis, but we're going to provide you with strategies to better manage your pain, better manage aspects of your experience with your disease. So you'll learn different relaxation-based interventions that can help to calm down some of your experience with that visceral hypersensitivity. Also, as I said, stress doesn't help anything, and in today's world, there's no shortage of stress. And so learning specific strategies for better stress management is something that we can provide you in behavioral therapy. Coping and acceptance is another area where we can sit together and help you to process the emotions associated with having a chronic illness. And sometimes you know right away what those things are, and other times they kind of unfold in therapy. Though the therapy that's oftentimes offered for patients in our GI program is short-term, meaning that we have specific goals in the beginning, we help you address those goals, we help you better manage your disease, and then you get to go live your life. So therapy is not meant to be lifelong with a GI psychologist. And then we also want to help with lifestyle, so assisting in meeting the goals that you have for a healthy lifestyle, whether it be better medication management, improving exercise, taking a look at your nutrition, and then also making appropriate referrals when necessary. Something that patients can do sometimes in an attempt to avoid their pain is to avoid certain foods. So that's when we really work with our colleagues in nutrition to help to make sure that you have as much of a unrestricted diet as possible, which also can help with improvements in your quality of life. So in summary, your emotional health is just as important as your physical health. This is something that you should be talking about with your gastroenterologist and your medical providers. Just like they ask, how are you feeling? Remember to answer how you're doing emotionally as well as physically. Consider building an integrative team that includes a psychologist for helping with your overall health. And by addressing your mood symptoms and having a variety of strategies to cope with pain, your experience with pancreatitis can certainly improve. So thank you.
Well, thank you very much, Dr. Riehl, for that wonderful keynote talk. We are going to spend 20 minutes answering questions consecutively. We'll first have Dr. Wiley come up and answer questions over the course of 7 or 8 minutes, followed by Dr. Riehl, and then myself, and then we'll have closing comments.
Thank you. I will reinforce something that Dr. Riehl was alluding to, and that in my experience using both medicinals as well as referring patients to her for cognitive behavioral therapies and hypnotherapy, her results are every bit as good as mine, and she doesn't have side effects. So this is something to really consider in the big picture of things. With that promotional notice, I'll move on. So I'm going to start by saying as a researcher, I'm not a dispenser. Several of the questions that are on the list that I was given had to do with what the right ratios of THC cannabis products to cannabidiol might be. And honestly, that's outside my wheelhouse. Dispensers are very well versed in how to perform this goal or achieve this goal, and I would discuss this with whoever your trusted dispenser might be. So let's start with cannabis, effective method to control pain, improving appetite. Well, the jury's out. There is anecdotal evidence that I presented under control of pain that says possibly. I think we need to identify which patient subset is this relevant to. Appetite, a lot of anecdotal experience out there about the munchie effect. In my clinical experience, I see it more with lower doses of drugs or medications such as Marinol than I would see it with higher doses that I'm using to control nausea, and that's my primary use, and pain secondarily. Does it control abdominal pain with people with pancreatitis? That was addressed in the talk. We need larger studies. The one study I presented, or two studies I presented, basically have less than 10 or 12 people in the interventional arm, and this is just not enough to really come to any kind of important conclusion about the effectiveness. And we need to have, lots of things need to be addressed: gender balance, ethnic balance, there's just age issues. All of these need to be addressed in future studies. Is it a good supplement for other pharmaceuticals in managing pain? I think this is promising, and it may well be that we can decrease use of some other opioid medications, for example, by having cocktails that might include a cannabinoid product. For best control for pain control, we don't know, but I would say if it was on my end as a user, or not personally, but as a user in terms of using these in a clinical setting, probably I would be more comfortable with the edibles as opposed to the inhalants. And the reason why is that we know that there's potential side effects of the inhalants. The disadvantage is inhalants work very quickly, and the edibles take some time to work, but you're not exposing the lungs to potential other products that are in the product you're inhaling. I don't know what the trick is for getting pain relief without getting high, other than the highness comes from the endocannabinoid 1 receptor activation in the central nervous system, and that's primarily an effect of the THC, the tetrahydrocannabinol. Is cannabidiol oil, cannabis oil, effective for pain due to chronic pancreatitis? I think this is going to be a stretch, given how it works. It does not seem to have the same affinity, meaning a binding ability to these endocannabinoid 1 and 2 receptors. It seems to work more by improving the availability of the endocannabinoid system to do its thing, which is an attractive feature, and it does not have the psychotropic effects as we mentioned. How do you measure the quality of the CBD or cannabidiol oil? Well, outside of that one approved product that is available for the, officially approved by the FDA for treatment of childhood seizure disorders, that's the only product that we know exactly how much you're getting of the cannabidiol, as far as I know. There are labs that will measure this, and it can be done. It's just that it's not routinely done in what you buy off the shelf. So that's a big issue, particularly if you're doing research on this. You have to know how much of the good stuff is in there and that it's not adulterated. What is the difference between cannabis versus oxycodone for pain management? Well, very good question. They work through two entirely different pathways to begin with. One works through the opioid pathway, mu receptors primarily, but there's a slew of other opioid receptors that can be involved in pain. The cannabis works through the endocannabinoid pathway. So I would say in general, the thinking is that the endocannabinoid system is more of a modulator of the pain, including the opioid receptors and other pain receptors. So for example, in my own research, we've shown that endocannabinoid receptor 1 modulates or regulates an important other receptor that's directly involved in pain, including pancreas pain, called the TRPV1 receptor. Which we don't have to get into the details right now, but seems to be a modulator as opposed to a direct effect on the pain neuron. It's modulating other pathways that are linked to pain. This is a little bit out of my wheelhouse, but is cannabis legal in Michigan law? Illegal by federal law? Can cannabis be? Well, it certainly is being used in Michigan, and so people are picking it up through dispensaries and trying it on their own, and then if you have a license to dispense, you can, as a physician, you can dispense it as well. What kind of doctor, this is sort of a secondary question, what kind of doctor can prescribe medical marijuana? You need a license to dispense, and but it's doable. Common side effects, I addressed this in the talk. I think probably the biggest ones are somnolence and just lethargy. But the sort of the psychotropic effects also, the kind of the high can be considered as a side effect. The edibles versus inhalants, do edibles in cannabis have similar side effects? I'm always a little concerned about the inhalants for people, particularly if you have a comorbidity such as COPD, some sort of lung problem. Using an inhalant makes me a little bit squeamish in that scenario. Are there safety concerns for the patient that uses both cannabis oils and hydrocodone? I'd be more concerned about the long-term use of hydrocodone. I mean, basically the literature is pretty clear. If you use these potent opioid agonists like hydrocodone for long periods of time, it seems to attenuate, and the literature is pretty clear now that it's just not that good as a long-term strategy for chronic pain. Very good for acute pain. But over time, you have the whole development of potential addiction, which is a real serious issue societally now. The use of cannabis problematic for people who have substance abuse. I guess the simple answer would be yes, but I'd be actually more concerned about the long-term consequences of alcohol outside of this last question, which does concern me. We don't have a lot of data on this, and that's would cannabis be more or less dangerous in the use of a teenager? So this is an issue for all of us, and I don't study the pediatric population, but we do know that up to a certain age, the brain is undergoing a significant amount of plastic changes. And there are some data out there on animal studies, and it's evolving with the human studies, that there could be consequences to chronic use of cannabis or chronic cannabis exposure earlier in life, like teenage years, and it might have long-term effects that we are not aware of yet. People are concerned about it, though, because of that neuroplasticity, that brain is finally reaching its final stages of maturation. And could this have an effect on that? Is cannabis dangerous? Well, that's a good question. Is cannabis dangerous for people with pancreatitis? There's one report done by Jamie Barkin's group, published a few years ago, that does demonstrate that there may be a subset of people that actually get pancreatitis with the use of cannabis products. We don't know what the mechanism is, and it's a small, if it happens, it's going to be a relatively small group of people, but even if you're one of those people, then it's a significant side effect. So there are some reports out there, relatively small samples, that there might be risk in some patients or some individuals for risk of developing pancreatitis after exposure. I think it's probably chronic exposure to cannabis products. We don't know why that is. I've looked into the literature and I've tried to think about why that might be in terms of mechanisms of action, but I can't come up with a good reason or a good hypothesis that would explain that, other than it might get into this whole pharmacogenomics thing about how we metabolize these things and could you develop toxic metabolites. Is smoking cigarettes by itself a risk factor for chronic pancreatitis? Does this apply to cannabis? Probably less so, I would guess, outside of this higher risk population with lung problems. Smoking tobacco has nicotine in it, and which has well-known, well-described effects on neural pathways, and cannabis does not. I guess the two together, could they have some summation effect? I would be more concerned about tobacco use than cannabis use, strictly from that question. I think that's it for me.
Thank you, John. We're going to move on to the second set of questions with Dr. Riehl answering questions about behavioral therapy.
All right, so I did address some of these questions during my talk, but I'll run through some of my thoughts again. So how is behavioral therapy used to manage symptoms associated with pancreatitis? So certainly giving you coping strategies that, in the moments of pain, what can you do? Relaxation strategies. Certainly there are various types of relaxation strategies that I can talk about, but also how we think about our pain and or how it's impacting us at any given moment. Certainly when you are presenting to a psychologist or a mental health provider to address a certain medical condition, you'll have the opportunity to talk about what are your goals. And so dependent on various symptoms or ways that you're impacted by your medical condition, you guys can come up with strategies that you will learn together. What's the best form of behavioral therapy for pain? That goes along with what I was just saying, that oftentimes treatment can be individualized, and it will be individualized to you. So sometimes my patients really want to dive into some of the cognitive ways in which their thoughts impact how they physically feel and emotionally experience different aspects of their health. And so for that type of patient, cognitive behavioral therapy can be effective because it really dives into helping you to better assess how maybe thoughts that are catastrophic or really focused on the black or white and forgetting about the gray areas of our life. CBT can be very effective, so that's different than CBD. CBT, cognitive behavioral therapy. Other types of therapy would be mindfulness-based stress reduction techniques that were developed by John Kabat-Zinn several decades ago. And we also see patients benefiting from ACT, which is acceptance and commitment-based therapy, and other mindfulness-based interventions. Hypnosis is always a big one that people are interested in. It's not clucking like a chicken when a bell goes off or losing control. In my clinic, we use medical protocols for hypnotherapy to address digestive concerns that are very well researched, have a strong evidence base behind them, are helpful for patients that have even failed other medical treatments. So I think it certainly would be worth exploring the use of medical hypnosis for the management of your pain. And does meditation have any tangible effect? effect on minimizing painful pancreatic attacks. So sometimes I think we put too much clout into what meditation is. Meditation is really a practice that oftentimes requires lifelong implementation. So you can get very good at meditation, but it's not a snap your finger and your brain turns off type of concept that I think sometimes people have a misconception around. So meditation can help you to be centered in the moment and non-judgmental about what's happening in that experience, but it certainly is something that takes a lot of practice. So if you're having more of a painful attack and you have not a ton of experience with meditation, you're not likely to find it to be helpful right away. But I think over the long term, having meditation a part of your daily practices and your skill set can be very effective. Most insurers do cover behavioral therapy. We bill under a mental health diagnosis or a behavioral health diagnosis, and sometimes if you're using health and behavior codes, we bill under a medical diagnosis. There are other health psychologists outside of Ann Arbor. Our program is a bit unique in that we have two GI psychologists that have extensive training in the management of our GI conditions, as well as being fully integrated into our program. However, when you're looking for a mental health provider, you want to look for a health psychologist or someone with experience in working with chronic health problems or conditions. Those that are using cognitive behavioral therapy or other evidence-based behavioral therapies that I've discussed, such as mindfulness-based stress reduction or ACT. You also want to have a nice connection with that person. So sometimes patients will say, you know, I've been working with this person for a while and I just don't know that I'm really getting anything out of it. It might be time to either have a conversation with your therapist about, you know, what are our goals and what are we trying to accomplish here? Because ultimately you are a consumer, and while it can be an intimate relationship that you have with your therapist and the things that you talk about, it's very different from a friendship. And so you want to make sure that you're learning tangible tools and strategies and skills that actually are improving anxiety, depression, and pain management. And is it just as important to have your counselor as your GI doctor on speed dial? This is also going to be dependent on kind of the type of therapeutic relationship you're looking for. So in my clinic, if there was an emergency, it's very difficult to get a hold of me in an emergency situation. So suicidal ideation or very severe symptoms of anxiety or depression, you would want to have more of a general mental health provider or psychiatrist that you might be able to get a hold of on speed dial or calling 911 if there was a concern about your safety and well-being. But when it comes to thinking about, you know, I'm going to make changes in my treatment plan, or my pain has been worsening lately, certainly having access to a clinical psychologist who specializes in health can be effective, and somebody that you should consider reaching out to when it comes to the management of your health. So finally, besides depression and anxiety, what other mental health issues are present in patients with chronic pancreatitis? Again, we need to do more research, but substance abuse is certainly one that comes to mind and may require working with a mental health provider that specializes in substance abuse. Potentially disordered eating is also one that we would want to assess for. And again, that goes back to if you become too avoidant of foods in an attempt to manage your pain. Do we see PTSD in people with chronic pancreatitis? So we can't classify medical conditions as having PTSD according to the DSM-5, which is our kind of diagnostic book that we use. But we certainly, I would suspect that patients have experienced post-traumatic stress symptoms. And you know, we are really doing exciting research in the area of assessing post-traumatic stress in patients with inflammatory bowel disease. Dr. Tiffany Taft at Northwestern University has done an early study that showed that up to 32% of patients screened positive on the PCL, which is a PTSD screening, And so I think that this is an area of research that we really should consider of transitioning into other GI conditions. And that certainly if you've had a traumatic incident around your diagnosis, hospitalizations, medication use, pain, seeing a therapist is certainly recommended, and there are also therapists that specialize in patients that have experienced medical trauma. So either talking with your medical provider or even consulting with a GI psychologist, we can make the decision together about who best will be helpful to address aspects of trauma.
So in the interest of time, I will briefly touch on some of the questions. There are going to be more questions than I can answer in the remaining time. What triggers the pain for patients with chronic pancreatitis, including those who have had pancreatic surgery years ago? My slides broke down the etiology of pain in terms of anatomic causes, organs versus neural pain, whether it's the nerves themselves or the central nervous system. And in terms of flares, that's a little bit more difficult to answer. Sometimes there can be triggers, particularly smoking, or if there's alcohol, sometimes medications, but most of the time we may not have an explanation for why people have had flares. We accept this to be more the natural history of their disease. What is the cause of sudden onset of severe abdominal pain with high liver enzymes and often lipase values? Lab values remain high more than 24 hours, but pain resolves after 1 hour. I'll just provide a short answer on pattern recognition with the elevation of liver enzymes. This is suspicious for some problem going on in the bile duct, maybe a partial self-limited obstruction. A common example would be gallstone pancreatitis. 3, is pain always an indication to get labs in recurrent acute pancreatitis? People who've got recurrent flares may be hospitalized or may sometimes stay at home managing this. Well, whether or not to get labs, it kind of depends on whether these flares resemble what's happened before, or if there's something atypical or new. If the atypical or new or more severe, of course, you probably want medical attention and get labs and an evaluation. If it's more run-of-the-mill, you never want to consider be a run-of-the-mill and think nothing might be going on. But if it's pattern recognition, it's what you anticipate. Staying at home, NPO liquids, letting the pain resolve and slowly reintroduce food is fine. Is it gas that causes the pain? Any remedies? I'll just focus this question. People who have chronic pancreatitis may have maldigestion from exocrine pancreatic insufficiency or bacterial overgrowth. So in that regard, it can give rise to gas generation and discomfort. Certainly worth checking that out, making sure you're taking your pancreatic enzymes. If you have insufficiency, considering bacterial overgrowth and antibiotic treatment. Why does my pain worsen with physical activity? I have not been able to prevent pain by use of yoga, taking Motrin, hydrating, and resting in bed days before and after. I appreciate the extent this individual has tried to mitigate pain using a variety of techniques. I don't exactly know what the source of pain here is. This sounds suggestive of musculoskeletal pain, but this would really require more in-depth history and physical examination and perhaps involvement of a pain specialist to tease apart. What kind of treatment can be given to control pain for chronic pancreatitis? We didn't get into that in detail, but you've heard some specifics come out in the course of the 3 talks here. We talked about anatomic causes of pain. Sometimes that can be managed with short-term analgesia. If it's persistent, there may be a structural problem that needs to be addressed, maybe by surgery or endoscopic treatment, particularly if it's persistent. There is a role for pancreatic enzymes or perhaps antioxidants, but the messages are mixed. We have talked a little bit about the neural modulation, and Dr. Wiley went into that in detail. This goes beyond antidepressants. We talked about gabapentinoids and also the cannabinoid pathways as potential options. And then there are other therapies we tried to bring to light here during this event, and that is acupuncture. There's some limited data for that. as well as behavioral therapy. Certainly, it's underutilized and worth considering. Can reducing gastric acid with omeprazole relieve stomach pain? This raises questions about other causes of abdominal pain. We mentioned gastric ulcer and so forth, although suppressing acid can also help with release of pancreatic enzymes to improve digestion. This will be the concluding slide here. Questions about neuropathic pain and burnout. Why does abdominal pain sometimes persist after total pancreatectomy? This is that phantom pain. You remove a leg that's been painful, but you still sense the pain present even though the leg's gone. Same thing with the pancreas. This is something I emphasized in my review of pain. This is the involvement of the neurologic pain or neuropathic pain. Will patients with chronic pancreatitis always have some degree of pain? The answer is no, not all develop pain. If there's an anatomic cause that could potentially be addressed with constant unremitting pain for years, what we hope to achieve is improvement or lessening of the pain and improvement of quality of life, ideally with successful use of these neuromodulators. That's been shown at least one randomized controlled trial. Spinal cord stimulators and peripheral nerve stimulators for treatment of pain due to chronic pancreatitis. There are case series using these as salvage treatment for people who have visceral or peripheral pain. Haven't really been involved in that too much, but that really would require involvement of a pain specialist and sometimes someone involved in anesthesia to consider that as an option. So without further ado, I am going to skip over the questions on opioid analgesics that was touched on in part by Dr. Wiley, but also myself in the course of the presentation on pain. Quick closing remarks. Thank you all for attending. Thank you for your patience with our technical difficulties early in the day. I hope you have learned as much as I have learned listening to this excellent, outstanding set of speakers. What I would like you to remember is that following this event, you'll receive communications for several things. One is to complete the true-false questions that you did prior to the event. This provides a measure of learning and effectiveness of our speakers. Those who complete the questions both before and after the event will also be eligible for a drawing for prizes. This will also provide you with an opportunity answering these communications to suggest topics for next year. All the topics we presented this year came from last year's suggestions. We want to meet your needs. The communications will also provide you with access to the electronic syllabus. You can spend your leisure time going over these slides, and also a link to a Michigan Medicine YouTube video that we will post for this event, high quality images, high quality sound for you to look at in the future. Thank you very much and have a nice afternoon.